So thanks to Becky and to Dr. Armstrong for the opportunity to speak to you a little bit about my research. I kind of feel a little bit, in the shadow of 3 inspiring patients, so hopefully I'll not bore you too much in the context of what you've just heard. I'm going to talk a little bit about my research and some sort of extrapolation that we've done from it that I think is hopefully relevant to World Kidney Day being about kidney disease and women's health this year. So when I did my PhD in London, I became involved in a big multi-centre, multinational research study. So a multi-centre, multinational, randomised, controlled, factorial design, double-blind trial, which I always struggle to say when I present it. And I'll explain a little bit about what that means in a second. And it was called REPAIR. And we called it REPAIR because obviously we were thinking about repairing and protecting people's kidneys. The study was sponsored by University College in London and run by an absolutely excellent clinical trials unit at the London School of Hygiene. These guys are fantastic, and I think their relationship with the patients in particular is one of the reasons why this was such a success. The study was funded by the Efficiency and Mechanism Evaluation Programme, which is part of the MRC and the NIHR. So just to give you a little bit of background, because I know we've got a variety of different people in the audience, we wanted to look at this thing called remote ischemic preconditioning, and it's quite a funny concept. Basically, back in the 80s, there was a medical student who was doing some research looking at whether or not having angina might protect you against having a heart attack. And so what he did was he got some dogs and he did some brief occlusions of the circumflex, one of the coronary arteries, and he basically tied it off intermittently for a couple of minutes, and then he gave them a heart attack. And what he showed was that this little periods of ischemia or reduced blood supply to the heart was able to protect the heart in a way that has never been reproduced with any other treatment. So it's better than any of the drugs we've seen. It's got more evidence, it's more reproducible than any other treatment. And so people went on from that and they looked at occluding the blood supply to other organs and saw that that could protect as well. So initially they did the coronary artery beside the circumflex, and then they did the organ supply to other organs. And basically you can do this ischemic conditioning thing to any part of the body and it protects the whole body. So you can cut off the blood supply to your kidney, it'll protect your brain, protect your heart. And then at UCL, some of my colleagues showed that you could do this non-invasively using a blood pressure cuff. And so what you do is you put a blood pressure cuff on the upper part of your arm, inflate it up above your blood pressure, leave it up for 5 minutes, deflate it for 5 minutes, and we repeated that 4 times. So you probably need 3 times to have an effect. But we thought we'd do 4, just belt and braces and make sure that everything worked. And you need a sort of a threshold of ischemia in order to induce this protection. It's a bit of a strange thing. We don't completely know why it works, but we know that it stabilizes mitochondria, so it stops your cells from dying when they're exposed to a lethal insult later down the line. It's got 2 windows of protection, an early phase, which I don't know where the pointer's gone, but you can see there's a peak initially when the intervention's done. Lasts for about 4 hours, and then it comes back again at about 24 hours, and it lasts for 3 or 4 days. And we still think that that might be due to some sort of genetic upregulation, so a bit like hibernation or something. The cells are going into a sort of a sleep, and they're preparing themselves for something that might come later. And it's in this study, we basically wanted to look at that and whether that would protect kidney transplants, because as you all know, when you take a kidney transplant from one person, you cut off the blood supply completely, and that causes damage to the kidney. We try to reduce the damage by putting some special fluid into the kidneys that tries to stabilize the cells, and we put them into ice. We do various things to try and minimize the damage, but there's still damage. And obviously in living donor kidney transplants, there's no ice involved, but there's still a period of time which we call warm ischemia, where the kidney is not connected to one or other person. And we wanted to look and see if this would help. So what we did was we got 406 kind donors and recipients of live donor kidney transplants. Living donors, because it's a bit easier in a research study when you're going to prove something, hopefully for the first time, you know when they're going to have their kidney transplant, and you can sort of govern the other factors. It's not going to happen in the middle of the night or anything like that. And we basically randomized them, so we got a computer package to decide whether they would either have this blood pressure cuff thing done immediately before they went to surgery, which is the early preconditioning, or we randomized them to have it 24 hours before, and we called that late preconditioning, which I appreciate is confusing because it happens earlier, but that's what we decided at the time, or both, or neither. And this is the basis of this factorial design. So it's a way of increasing efficiency in clinical trials because you can investigate two different things in the one study with a lower sample size. I hope there are no statisticians in the audience because I don't want to go into it any further than that because there's some complex modelling that needs to be extrapolated from it, but that's the basics of it. To come on to some of the things that have been said earlier in the day, so our baseline characteristics, as you would probably expect, so although chronic kidney disease is more common in women, end-stage kidney disease is more common in men because I guess some of the things that we saw that affect the kidneys in women that increase the chronic side don't progress in the same way. So you get this sort of male-female difference. And so we had more females in our, we had more female donors, but we had more male patients, which one of the talks earlier alluded to that kind of pattern in live donation. And they were all, the donors were all fit and well, and they were screened, and they all had pretty good kidney function. And this is what we saw. So we chose as our endpoint. So in a study, as some of you will probably know, you have to pick an endpoint that's going to say whether this works or it doesn't work. And what we picked was a 5-hour ihexol GFR. So this is a formal measure of kidney function where you turn up to the hospital, we inject a little bit of a dye that's what we use in the CT scanner, and then we measure how much time, we measure how that clears over time from the kidneys. Allegedly a very accurate test, but as the patients will probably appreciate, it's a bit of an ordeal. 5 hours in the hospital, 4 blood samples, it's hanging around, and it's quite a lot. So we found some patients weren't able to attend for that, so we lost some numbers. But we showed that this early conditioning, so doing it immediately before surgery, and this was done to both donor and recipient, was protective, but frustratingly not really enough to say with certainty that it was going to work. And part of that, I think, is related to the complexity of this endpoint, but it is what it is, and it, in terms of the study, we were a bit disheartened and a bit disappointed at this point because we didn't quite get there. But then we saw this. So we've been following up the patients in the study for the last 5 years. They'll all have gone through 5-year follow-up by May of next year. The London School of Hygiene have managed, by hook or by crook, to get over 95% of the patients complete data the whole way through. That's really unusual for a clinical study. Most of them will have maybe 70, 75% follow-up if you're lucky. So over 95% is really good. And I think that says something about, you've seen the patients today, the kind of people that they are. They're very engaging with what's going on. They look after their health. They're very involved with things. But also there's a real theme of people wanting to give something back because they're grateful for the care they've received, which I think, considering what we've heard people have gone through, is amazing. And it was just a real privilege to do a study with this group of patients because of that. And what we basically showed was that over the 5-year period, and this is the data that we do have, there was a significant improvement in kidney function in the patients who had this procedure done. So it's about 5 mils per minute of GFR, so 5% in basic terms. But it's about a 12% improvement. And what it basically means that if you've had this done, it should say early RIPC at the bottom instead of late, by the way. At 5 years, your kidney function is about the same as what it is without it at 2 years. So, you could argue that that means you might get 3 years more from your kidney. I think the jury's still out about that, and we're doing some modelling, but it improves kidney function. And we also saw that it reduced the risk of graft loss and it reduced your risk of death. So the red, these are kind of inverse Kaplan-Meier. So I don't know if anybody's familiar with survival curves, but they're a bit upside down. So just so you know what you're looking at. The red ones are the control group. So they didn't receive the early preconditioning. The blue ones are the people who did have it. And on your left, so you've got the people who had just preconditioning just before, so there's obviously a difference. In the middle are the people who just had the late, and if you had any form of preconditioning, you obviously get the additive effect of both of those. So there's quite a significant difference in the mortality and graft loss rates. To do a study to look at this in depth, average kidney transplant lasts about 15 years. So we need a very long study or a big number of patients to show this definitively. So it's just a trend, but it was there, and it reinforced our idea that this is safe. So whatever else you can say about it, it's safe. And the head of the trial steering committee is a professor of epidemiology at the London School. And afterwards he said, why don't we look and see who gave kidneys to who, and is there anything we can learn from that? And I think it was quite interesting because I think as physicians, we're so buried in what we're doing that often we don't think about what other people think. What does the general public think? We've heard not very many people know that they've got 2 kidneys and their kidneys make urine. And actually, what do people in the public think? And actually his baseline for this was that he didn't think that you could give a kidney to someone you weren't related to. And so he wanted to look and see whether, what was the case. And I sort of pointed out to him, well, actually, all deceased donors aren't related to the person they're donating a kidney to. But for some reason, they still thought that if you were a live donor, it had to be a relative. I think that's important for us because we're always trying to encourage people to talk about live donation. But actually, if a lot of people think that actually, if I don't have a relative that's suitable, there's no one else to ask, we're not really educating people properly. So it's really important that we do raise awareness. And what we saw when we looked at the patterns of donation was that the most altruistic group, I remember one of our research nurses getting very excited about this because her take home from this was wives are the best. Wives are better than husbands. Wives give their kidneys to the husbands don't care. And obviously, this is just crude numbers. And so you can't, more people with more males get end-stage kidney disease, so the data is not as pure as that. But and equally, you could argue by looking at that if you're a male, you're more likely to give a kidney to your friend than a female. But this is essentially what we saw. And siblings about equal, and parents, the mothers donating to children. And there could be all sorts of economic factors and other things that we didn't look into because this was a retrospective analysis. And actually, when you look at the data, some of this, and especially in America, they're good at collecting this kind of thing, but in the UK, we're not so much. And actually, maybe there is more to, enhancing people's knowledge about live donation that we could learn if we looked into a bit more. So, as you've heard, one of the key things about today is increasing the knowledge about transplantation and living donor kidney transplantation, especially. Why is it important? It's important because the practicalities, people are managing all sorts of things in their life, both the donor and the recipient. And actually, if you've got a timed procedure that you know when it's going to happen, you can work towards that. You can put everything in place for that. You know when it's going to, you know everything about what's going to happen, and you can work up towards that. So you can make sure everybody's as fit as possible, that there's no potential problems. You can make sure, obviously, it's not the middle of the night, because I think kidneys, like babies, they like the middle of the night. You can screen your donors to make sure that they're completely fit. It has an effect on outcomes. So living donor kidney transplants are just much better than even deceased donor kidney transplants. So transplants are the best, but of the transplants, having a first kidney transplant from a living donor is by far and away the best in terms of outcome, and we'll talk about that shortly. It also allows preemptive transplantation. So you've heard from Nicole, so she never had dialysis because she was able to receive a kidney from her dad. So going on dialysis in itself has a prognostic implication, so it reduces your life expectancy. So if you can skip that bit altogether, that is better for the health of your patient, not to mention the lines and fistulas and all the other bits and pieces that are involved with dialysis. It saves a huge amount of resource to the NHS. So the patients that are on who are transplanted at the moment save the NHS, I think it's £50 million a year or some colossal amount of money. And it's £25,000 per patient per year after the first year compared to dialysis. So it's a vast cost saving to the NHS. We need more kidneys. So if more living donors give kidneys, then obviously we're expanding the donor pool. So I don't know if some of you have seen some of the slides about World Kidney Day that have been floating around, but this one just caught my eye because of this. There are 5,200 people waiting for a kidney, and only 3,300 transplants are carried out each year. So there's a big mismatch in supply and demand. And so increasing awareness about live donation is really important. And there's benefits to the donor. And there's, the psychological well-being. I mean, I've got 2 small kids, they're 4 and 1, and I would happily give them a kidney tomorrow if they needed it. And there's that kind of, your relatives want to help you. People are often really understandably worried about making their relative or their friend into a patient, but actually they do gain from helping you as well. And I think especially, people who are in, relationships with you, they will want to do that. And it has a lot of psychological benefits, and that's been well documented in the literature. This is a slide from NHS blood and transplant, or organ donation and transplantation. It basically shows the percentage, because I thought someone would probably ask how many kidney transplants come from live donors in a year. And so the palest colour is living donors, and the other 2 blue colours are the deceased donors. So we've got deceased after circulatory death, so people whose heart has stopped. I've got people who are brain dead, which is this sort of stereotypical brain dead on ITU where we withdraw treatments. There's different types. So you can see that although the living donors account numerically for more than the other groups individually, we're still behind. So deceased donors are still, the most common. And in other countries, that's not so much the case. Other countries have a bit higher rates of living donation. We just need to think about how we're going to move towards that. And I don't know if anybody saw, there was a lady a few days ago in the media who was quite angry, I think, because she'd obviously had a transplant and the transplant had failed, and that was from a deceased donor. And I think, there's lots of conversations that we should be having with people as a whole about kidney transplants, about, the risks of, especially, the different types of organs that we have available, and how we make those better for patients, and what the expectations are, so that people know why, living donation is such a big focus. So Aisling Courtney, she's a nephrologist in Belfast, and she has revolutionised their programme by basically streamlining the process they have for donors. They get everything done in a day, which I said this too. My daughter's got a friend whose dad's got a kidney transplant, and I sort of recently mistakenly said to them, in Belfast they do it in a day, and they went, what? It took us 2 years to get to this point. So that obviously, makes a big difference. But a lot of how they've changed their programme is talking about acceptable risk. And we've heard a lot about risk today, and the media, as Kate said earlier, how the media latches onto it's a 10 times increase in risk, but 10 times 0.00001 is still a really low risk. So it's just talking about what an acceptable risk is. And I think as doctors, not assuming that an acceptable risk is going to be the same for each person, or that an acceptable side effect is going to be the same for each person. So it's involving the donors in those discussions. Now, clearly there are limits. We can't let unfit people with poor kidney function give kidneys. But I think, it certainly challenged me to think about the people we see coming through and what is an acceptable risk. Donation does, as we say, have benefits for donors. And not being able to donate has been associated with negative psychological outcomes. So parents especially, I think, that haven't been able to help their children. Live donors are always going to be healthier than deceased donors, and I think that's one of the points they made about the Belfast programme, that we accept quite a lot less healthy in terms of the deceased donors. There's obviously a reason for that. We don't want to make people who are already compromised in terms of their health worse, but it's just thinking about where the balance lies. And we've got a responsibility to counsel people appropriately. And talk to them about exactly what the risks are. And I think the transplant surgeons are brilliant at this, because they spell it all out very, very, in terms of the percentages and the numbers and the local level. But just, again, what's an acceptable risk, and who ultimately should decide. I mean, obviously we take the final decision on whether someone should go forwards, but I think that is becoming more and more of a discussion. So what are the risks, briefly? Historically, and people might have heard this, there was a study in Norway that was always touted about, because it basically showed that if you gave a kidney, you were healthier than the average person. The problem with that is the average person can't donate a kidney. So actually you weren't comparing these people with their compatriots, if you like. And so in the last couple of years, there's been 2 studies published where they basically took a group of people who were kidney donors and they compared them against a group of people that they thought might be able to give a kidney. Now, obviously that's not perfect, but it's better. And what they showed was that there is an increased risk of end-stage kidney disease. And a lot of this is related to obvious things. So if you've got high blood pressure, if you're overweight, or if you're older, you're obviously going to have a higher risk of developing kidney disease if you're left with one kidney. And I think we'll all recognise that. But what they realised was that actually we can't predict the risk so well if you're 20, because we haven't got enough of your sort of life to know what you'll develop, because most people are fairly fit and healthy at that age, arguably. And so we don't really know, and that became especially important in terms of a family history of renal disease. So one of the studies was again in Norway, but they actually isolated the controls from a population that was actually quite a small genetic pool, so where the controls actually really true controls. And what they said was that actually a family history of renal disease should be viewed as a risk factor in these people, and different units have different ways of investigating that. There is an increased risk of getting protein in your urine. Arguably, some of these things are now treatable because we've got tablets that we can give people to reduce their blood pressure and reduce proteinuria, but it is there. There's a risk of hypertension, and I'll show you the UK figures in a minute. And then feeding back to what Kate said, so there is a risk of hypertension and preeclampsia. So we saw that earlier, that basically if you've got CKD, there's this sort of CKD effect where you're more likely to get these things in pregnancy, and it's not necessarily related to, you know, how bad your kidney function is, because people with a stage 1 CKD are still at risk. It's the same thing with this. You take one kidney away, essentially you're going to expose them to risk. And interestingly, the figures that she showed are about the same as the ones that were shown from the donor studies. The one thing they did say is that the risk would be higher in women over 32, but actually those people are at higher risk anyway. So I think those risks are the ones that are very small to start with. They are increased, but they're still relatively low. And so long as people are counselled about them, they shouldn't necessarily be a reason, provided the person can accept that risk, to not donate. And then there's mortality. So a little bit of a debate again about this one, because there's a big study in America where they looked at people who had lost a kidney for other reasons. They're obviously not the same group entirely, and they showed that basically following them through with matched controls, there wasn't an excess in mortality in people who'd lost a kidney. But the Norway study showed that maybe there was. So I think, you know, again, we're talking about small numbers, and I think we, you know, to put an absolute figure on it at the moment is probably difficult, but it's small, and that's the main thing to say. So just in the context of the UK, so the proportion of living donors who are on blood pressure medications, 5% at a year, 8% at 5 years, and 12% at 10 years. So is your dad taking any medication? No, so he's done brilliantly, although it is still, you know, 5%, 8 and 12, still, you know, small. Creatinine, so I think creatinine's a bit of a difficult one to completely think about. One of our patients recently said to me, oh, you know, he's doing really well because his creatinine's much lower than his brother, then gave him the kidney, but the brother's like, you know, really, really muscly, and so obviously he produces more creatinine, so actually their GFR is arguably the same, it's just the creatinine slightly different, but there will be a slight increase in that, but, you know, you say at 10 years, it's not significant. But survival, so live donors, again, live donors are better than deceased donors. And if you have a live donor kidney transplant as your first transplant, so this is these figures are all comers, but if you have first kidney transplant live donor, your outcomes are even better. So back to our study, what about our donors? I think that the idea that wives are super and they're just better at giving kidneys to their husbands than the other way around is a little bit simplistic. I think, you know, end-stage renal disease is more common in males. When I multiplied the figures by 1.6, there was still a few extra women there, so you can take from that what you will. The risk of donation is lower in females, so both the risks immediately related to the surgery and the longer term risks, statistically less. I'm not entirely sure I can completely explain that. And so are wives more altruistic than husbands? Well, like I say, I think, and you could argue that the men are more likely to give a kidney to someone that's not related. So I didn't think I could talk about transplant without mentioning this. It's not specifically related to live donation, but obviously this has been very topical in the media this week because this consultation about organ donations just closed. So hopefully some people in the room contributed their views to that. And this is about whether we should have a program where we're all signed up to donate kidneys and other organs unless we object. That does increase the amount of organs. It has worked in Wales. I know there's various people that have ethical issues with it. I know I was talking to my parents about this, and my dad said, well, you know, that just means that if you don't opt out, these doctors are going to run in and start pulling all your organs out. I don't think that is ever going to happen. I think we're always going to take into account, you know, the wishes of people. But I think it's really important. And I think, like Kirsty said earlier, most people would accept an organ. So, you know, we've got a bit of a responsibility, therefore, to be part of that pool to donate. So basically, in conclusion in our study, we're doing some further work to work out whether this protective effect is sustained. But really the main point of it was to show that there are lots of people that do give kidneys to relatives and friends, and that is a really good form of treatment, and we've seen evidence of that today. End-stage kidney disease more common in males, so the slight preponderance in that might account for some of what we saw. The risks are slightly lower in females, and the overall risk of donating a kidney remains low. So the more studies they do, the more sort of confounding there is in a way, but the overall risk is low. But people should be aware of the things to look out for, and that's why, as Kirsty said, we see everybody every year, and that's just to double check that their blood pressure and their protein and all the rest of it is kept under control. And as I say, our preconditioning, our strange blood pressure treatment might improve outcomes, and obviously it's very cheap and cost effective, but the jury's still out on that until we get some funding to do another study. I just want to take the opportunity to thank the patients especially, and no matter where we speak about this, this just would not have been possible without people signing up to do it. And it was a real struggle at times to get people on board, but actually all the patients I spoke to in our own centre, I think all but about 2 of them signed up to do this. And being part of a research study when you've got all this other stuff going on, it's not a small ask. So we can't make things better without people giving up their time. Obviously all the staff in the centres and the team who were fantastic at collecting all the data. And that's it.
Thank you very much to Kristin. It's really nice to have a bit of research thrown into a day like this, and I haven't heard your talk properly before, so it was really good. Has anybody got any questions they would like to ask? Well, I might start with one if that's okay. So in terms of your study, do you see it as going further? I mean, it sounds as though there's some potential data there. So what's the next step?
So basically it's been a little bit confounded because there's been lots of other negative studies, and what we think, so when we set up the study we were aware that there were some potential things that might interfere with this preconditioning thing, and one of them was anaesthetic, and so we deliberately preconditioned the patients before they were anaesthetized, and we think that's part of the reason why our study worked and some of the other bigger studies didn't work, that and the fact that people ask me repeatedly, why does it not work in cardiac surgery, but it works in kidneys? And that just seems like a silly question to me almost, because they're so different. But I think that the biggest challenges are, firstly, we'd need another study because it usually takes 2 to embed something. Secondly, just the debate about the GFRs has been the biggest thing, but I don't want to go into that in a massive amount of detail, but just trying to convince people that actually something that sounds a bit weird, there's no money to be made in this, so the drug companies and things, there's nothing for them, so it's been challenging. But the patients, I mean, I don't know what you guys think, but most of our patients love the idea of having something done once that then might make their kidney function better. There's no risk to this at all. So there's 1,600 people in the cardiac surgery arm of the study and 2,100 odd in the PCI one, which hasn't been published yet. So I think once that comes through, if that's positive, it's going to gain momentum again, if that answers the question.
Any other questions?